Well, it really is hard to isolate that because we are at a place in lung cancer management where we have all accepted that immunotherapy has a lot of activity in this disease. We are using immunotherapy a lot in patients who are what we call in the second line setting, again, concentrating on non-small cell, meaning they've had some chemotherapy and now they're progressing and definitely they should get immunotherapy. The most exciting data that's coming out is the combination of immunotherapy with chemotherapy at the time of initial diagnosis for patients with metastatic disease. There are multiple phase 3 studies showing that regardless of histology, non-squamous or squamous, that combining an immunotherapy drug with chemotherapy can improve PFS, response rate, overall survival. To some extent, that's a little bit surprising because when you think about the mechanism of action of these, what we call checkpoint inhibitors that we use, it doesn't make a lot of sense as to why they should work with chemotherapy, but clearly there's really good activity combining the two together. So now we are at a juncture where everybody who is diagnosed with metastatic disease is pretty much a candidate for either immunotherapy alone right off the bat if they have high expression of PD-L1, or they're a candidate for a combination of immunotherapy and chemotherapy. There are small caveats that we can discuss, but overall, if you look at the data, that's what the data seem to suggest. But what that does is that patients at progression, they've had chemotherapy, they've had immunotherapy. So then the question becomes, well, what do we have to offer them now? And that has become, again, another sort of burning question because we sort of don't want to go back to the old-fashioned chemo that we used to do in the past. I mean, going back to docetaxel and things like that. But at the same time, we don't have anything established as the standard of care after chemotherapy and immunotherapy. We heard at this meeting many exciting combinations for patients who've had immunotherapy already, but they're all based on small phase 1, phase 2 drugs, some of which don't even have a name still attached to them, the usual license plate number that we get for phase 1 drugs. But it indicates that the field has sort of accepted that immunotherapy in lung cancer is the way to go and is the way to improve survival of these patients. And I think research is going to continue along that continuum, if you will, to find another approach using the immune system, maybe different angles of it, adding other drugs, and sort of to overcome the resistance that these tumors inherently develop when they've seen any kind of drug. So I think where we're going to go is to see more exciting immune combinations coming that would particularly concentrate on patients who are labeled as being refractory to immunotherapy up front, and then hopefully we can overcome all of that. I suspect we're going to see a lot less chemotherapy combinations, but I've been wrong in that setting before. I think we're going to start seeing molecular data coming in and targeted therapy added to IO, although that has to be done very, very cautiously because there are some toxicities that we need to worry about in that setting. So I think it's exciting. I mean, these patients have really good performance status when they come out of chemoimmunotherapy because toxicity is not usually that severe. So that's the direction we're going to go. We need better treatments for patients after chemo and IO.